So good afternoon, everyone. So today I'll be covering about the practical guide to about the high throughput scanners from storage, high throughput scanning, looking at the storage architecture point of view, and followed by the LAS integration. The agenda for this presentation I would be covering. I will be talking about the real-world use cases, followed by the lab and infrastructure requirements, and then the roadmap, which is required for the phase-wise implementation strategy. Now, one thing which we need to identify, what is the use case which we are looking when we are buying the high-throughput scanner? Is it going to take care of our digital workflow solution? And what are the challenges which we face in our day-to-day problems, like in the subspecialties? Because there is a shortage of subspecialty, there is always a delay in the turnaround time, and the glass slides movements and the geographical barriers to the expert consultation. So when we are evaluating for digital pathology scanners from different vendors, what are the things which needs to be considered, taken into consideration while buying, like which vendor will fit you well according to your institutional or hospital's requirement. The first thing, there are many operationals and image quality things one needs to take care into consideration when you're going for the demo evaluation. Because when we are going for the demo evaluations, definitely the hospital or the labs, they are carrying their own slides. Looking into it, what is the magnification the scanners are providing? Is it providing the 20x magnification or 40x magnifications? Okay. What is the time scanning it is taking for it? And there are many other factors which we also need to look when it's a high throughput scanners. And if you have any kind of urgent cases, does it have such kind of stat or urgent features, available? So if the scanning, the high throughput scanning, the scanning is going on, and if has to be stopped in the middle of the time, and to introduce the frozen section slides, and once the frozen section slides has been scanned and been assigned to the pathologist, it should again start from the previous where it has stopped. So these are the small points where it needs to be taken into the consideration when one is evaluating for the digital pathology scanners. Now, the file format plays a very important role because every scanners would come with a different kind of file format. Now, do they have the universal kind of file format available with them? Because eventually it would be going to the DICOM file format. But nowadays, even the TIFF formats also are available, which many of the AI algorithm tools have been developed. So keeping this thought process in the mind, when anybody who's looking for this evaluation, they should look at it, what would be the use cases, and according to the use cases, go ahead with the vendors and all. And what is the AI solution also available with them. Now, coming down to, apart from the digital pathology scanners, even the display monitors and the workstations plays a very important role. Because ultimately it's the pathologist who is going to be using day in and day out for the clinical reporting. And as per the new recommendation and guidelines which has come, the 4K Ultra HD monitors are also good, but now the guidelines also talks about 8 megapixels, and now even the 12 megapixels are also, which are the medical grade monitors, which are needed for the pathological reporting part, clinical reporting. And in this, the other important point we need to take care of it, that the refresh rate. Now, also the internet speed plays a very important role, okay? Because if the internet bandwidth is not good, there would be a flicker in the image, flicker in viewing those images. So these are the points of consideration when we are looking into the medical grade monitors also, and then coming down to the graphics and the storage part. Now, the lab and the infrastructure requirements, these are the very important points of consideration. Now, once you have evaluated with this scanner, with this vendor, you are planning to go ahead with it. But is your lab or the hospitals is ready with that kind of setup? Now, when I'm talking about the setup, there are many other pre-analyticals requirements for the slide preparations also. If the lab is not ready with those kind of pre-requirements, pre-analytics of slide preparation plays a very important role, Because many a times I have seen in the laboratory, they might be cutting tissue thickness in the different, microns and all. So the small consideration plays a very important role, which usually, at the time of prerequisite, application person from that company comes and check it, and they are then, once the instruments are installed, at the time of training, these are the small things which is taken into the consideration. Now coming down to the high throughput scanners, what are the scanners which you're looking? Are you looking only for the bright field, or you're looking for the fluorescent one? And in the bright field also, will it be able to do the scanning for the cytology images? Because in cytology images, you require the Z stacking, especially with the conventional pap smears. And also you need to take it into the consideration, will the scanners will be able to do the bone marrow biopsies or any bony tissues, even at the single plane. But it should also have the facility for the Z stacking and all. Now, at what level of Z stacking one is looking into it, that also you need to take it into the consideration, because once you go into the Z stacking process, definitely the time taken for the scanning will also increase, and the file size also will increase for that particular slides. So you have to make changes also in the pre-analytics and also while evaluating the scanners. Coming down to the continuous loading capacity, the scanning time also plays a very important role when you are evaluating the scanners. The scan timing for the 40X should be less than 60 seconds or equivalent to 60 seconds. More than that, definitely, for the high throughput scanners, it would not suffice the need. Because if you look at it in the histopathology laboratories, never the recommended size, which is usually mentioned by the vendors, is 15 by 15 mm. But in actual scenario, if you look at it, the size is never the 15 by mm tissues. Always the tissue size on the bigger size or the medium size, or it would be a FNAC slides, which is end-to-end coverage. So these are the things when you're evaluating, even in the demonstration, you have to carry those slides, and you need to see the image quality as well as the scanning time of it. Coming down to the IT infrastructure and data storage, here the network plays a very important role. Why the network bandwidth plays a very important role? Initially, if I would take 6 years back, everybody was talking like 1 Gbps would suffice the need. But in today's scenario, with the high-end scanners which are coming with a good resolution and good image quality, the internet bandwidth which one is looking is for the 10 Gbps. Usually in the hospital network, you will not see this 10 Gbps network speed. That's where the prerequisite from the vendor, you need to ask before in hand, what is the network bandwidth which will be looking for it? Because as per the new guidelines also, now it is talking about the 10 Gbps speed. Because when the images are getting scanned and they need to be transferred to the server, you require a good bandwidth of network. If the bandwidth of network is not good, then the transfer of the image to the server will take some few minutes of the time. Usually with this 10 Gbps speed, within the 1 minute of your time, especially if your image size is around 2 GB, within 1 minute of time, it will be transferring the image. But if your network speed is of 1 Gbps, then it would take somewhere around 2 to 3 minutes of the time. So this bandwidth is very important. Then followed by the storage architecture. Now in the storage architecture, where your hospital or the lab IT will play a very important role, and this also you need to discuss with the vendor IT, because they would be evaluating and they would be discussing with your management what kind of storage you're looking for. Are you going to scan the entire workflow and slide workflow? And how would you store it? You're looking for the hot storage, warm storage. Hot storage is where if you're keeping the images, when you want to see it immediately, it should be able to accessible to you. Same thing, the warm storage, what happens when after 14 days or 15 days of period of time, and when you want to see those images back, within a fraction of a second, you are able to see those images. And in cold storage, where you're storing the image for more than 5 years or 10 years as per the guidelines which talks about. So you're in that cold storage also, when it goes and when you're which are in the archiving stage, and when you want to view it back, you should be able to view it back within the fraction of 4 to 5 minutes period of time. So this is all the consideration which your IT and the vendor IT needs to talk with each other, and that's where you have to develop what kind of storage architecture you're looking for your laboratory thing. Then according to the what kind of storage are we looking for, the slide storage are we looking for it, and accordingly, if you're scanning say 1 lakh slides, then in 1 lakh slides, and if it is been scanned at say 40x, and the image size is between 1.5 GB to 2 GB, then you would require a storage of somewhere around 100 to 200 terabytes per year. And accordingly, you can increase your storage size, and plan it accordingly, because every year your slide might not be 1 lakh. It would be increasing by 10% or 15% of your this thing. So keeping in this mind, you have to plan your storage for the servers. Now, looking into the lab integration point of view, now we have seen in many of them, they buy the scanners, and high-end scanners. And most of the places I have also noticed, they are not barcoded. They are labeled, but they are not barcoded. But if you are buying a high-end scanners, you need to integrate that scanner with your LIS. Now, usually in the hospital, most of the hospital will have the HL7 messaging structure. But those HL7 messaging structure might be good for the hematology lab and biochemistry lab. But when it comes down to the histopathology laboratory, the histo module is having a vast kind of information present in it. When I'm talking about the vast information, there are the list of things like patient demographic, UHID, patient's name, gender, date of birth, then followed by the physician information, where you're consulting doctor and the pathologist who is going to report out digitally. And followed by this, the tissue type information. There are various different type of tissue types which are there in the histopathology lab as well as in the cytopathology lab. Those are all need to be incorporated in your LIS thing. Followed by not only it stop in the tissue types, but there are various chainings you might be doing it. Either in the, I think in most of the places it is in the automation. But there are people who would be doing in the manual setup also. So those information like protocol ID, antibody names, because in the lab they might be having say 200 or more than 200 antibody names. So those all needs to be captured and not leaving behind these special stains. So those protocol IDs and protocol name, your HL7 should be able to capture it. Now the ID patterns plays a very important role. Why ID pattern plays a very important role? Because it has the case ID information. Once the samples has been coming into the histopathology lab, where the accessioning people gives the number, that becomes the case ID. Once it goes to the grossing area, definitely it would be getting the specimen ID, and as far as subsequently the cassettes will be made and the block ID followed by the slide ID. Why I'm talking all those things? Because ultimately, these are this information which would be captured in your label, barcoded label. So when the machine is scanning it, it needs to capture. And how, for better understanding of this information in the digital layer, if you look at it, the top where you have seen the case information, which has the case information with the patient information, okay? Now, if you look at it, a specimen comes. Now, there would be a multiple specimen. For one patient, there would be a multiple specimen. Like example, specimen 1 or specimen 2. And in that specimen, from that particular specimen, you might be making a block A, block B, block C, and subsequently the slides. Maybe a block K, the first slide might be of HNE, followed by your ERPR slides, So they will be having a different number. So block K followed by block 2, which is be labeled for ER, and then 3 number will be labeled for PR. So this kind of all this information has to be integrated with your LIS. Currently in the histo module, what we look at it is they have the basic information, but this kind of segregated information with a case ID, specimen ID, which is not there. That's where the vendor over here, usually when we are looking from the integration point of view, vendor usually helps out, the LIS team. These are the things which is needed for us for the integration when we are looking for the complete digitalization of the workflow process. Now, whatever the message is coming, the message has to bidirectionally flow back again to your allies. When I'm talking about message flowing back to your bidirection to this thing, it means you have seen this case digitally and you have signed out the case. That information again has to go back to your allies, and that's where the completion of your cases will come. It also has now with this alliance integration. Now, suppose you want the images which you have marked, the region of interest which you have marked, or maybe say algorithm, which you want to attach it to your synoptic reporting, that also is now feasible because it's just one-click movement. With this integration where you have marked, the area, and you want to put that marked area in this synoptic reporting, it gives the case management software which is available, it gives the flexibility for the pathologist, mark the area, it will give the algorithm score, the algorithm will be reflected in your LIS reporting. Now, this is how the ID pattern for the things looks like, when human readable and how it is the machine readable. So the middle part, you will see the human readable ID, okay? Usually when the technicians are submitting the cases. But how the machine is reading, the OBR segment, which is in the HL7 code, the OBR segment is a very important thing because it captures all the data of the case ID, specimen ID, as well as the stain information which has been run for that particular patient. So this is how the HL7 message looks for your H&E slides. This might be for every stain which you're performing in the lab would have this kind of complex messaging structure. Usually when we give this data, this is the data, when the vendor IT gives this data to the LS, IT person from the hospital, when they look at this data, they get confused, and that's where a vendor IT should, help this. We are there, the vendor IT people are there to support the laboratory IT people to understand what we are looking into. And it's not very difficult for them to do the coding part for this information. So whenever the institute has planned, now they are going with this particular vendor, usually the instruments are not being made in India, they come from outside. And the time period which we look into it is somewhere around 2 months period of time of shipment. By that time, if the prerequisite has been sent, these are the things which we require for the integration process, we could fasten up the process of the installation and implementation. If this exercise is not done before in hand, so what happens, this delays your installation will be completed, but your implementation for the digital pathology scanners would not get completed. So keeping in this mind, now earlier our approach was very different. Now, going ahead, we know the challenges which comes, and we have learned in the due process. So, because people are buying the high-end scanners. In high-end scanners, you cannot manually, write all those informations and do it. So, these are the things which are supposed to be taken into the consideration. Now, we have worked with different homegrown LIS also. We have seen multiple challenges. In some places, we are able to integrated faster because they had the strong alliance IT support. In some places, we had seen a challenge with the alliance team where they had the basic knowledge and the implementation took longer period of time. So that's where if you are not having the histo module, I would that's a suggestion from my side. If a lab is not prepared, then lab should start preparing themselves for when you're acquiring a digital scanner. Because HL7 coding for the histo modules, I think if you're giving this information to your alliance team, they would be able to develop it up. Now, coming down to the implementation roadmap, once the integration has been done with the scanners and all, and with the LIS, and the information is getting passed on easily and smoothly, that's where the standardization of the scanners comes into the picture. When I'm talking about the standardization, I'm not talking about the validation. It means now we are evaluating the scanner. Now, evaluating the scanners, if the scanners is having an option of 20x magnification and 40x magnification, usually the from the vendor side, they will be doing this scannings for the 100 slide, because ultimately from the company side also they need to evaluate the process has been standardized properly, and then the handover to the technical staff, followed by the training to the pathologist. When there's a standardization process is happening in the laboratory, we are picking up the different types of tissue types and even the cytology samples. Now, it is not always we have to pick up the good tissue types. We also have to be prepared if the slides are coming from outside. They might not be a well-prepared slide. Good prepared slides, definitely the scanning, you will not face any challenges, you will not find any out of focus thing area. But when the slides are coming from outside, that's where the challenge comes. So when in the evaluation of the scanners, you also need to also look that it also gives you option of, making a manual area of interest. What I mean about manual area of interest, because if you're buying a full automated scanner, it will be doing a continuous loading and it will be automatically adjusting the area of interest and doing it. But if you're getting a slides from outside and there are too many air bubbles and there's a crack on your cover slip and you want to avoid those areas. So the manual intervention, the scanner should be able to give it, and in that process you can make a multiple area of interest, and with that you will not be able to see the blur images. So usually when you look at when the slides are getting scanned, you'll only find one single area of interest. But when manual intervention, when you're looking at it, you can make multiple area of interest. So you will not see those kind of out of focus issues when you're getting the slides from outside. So in this readiness of validation, when we are taking care of it, after the standardization of the scanner is completed, then comes when we have completely trained the technicians as well as the IT. Why IT plays a very important role over here? Because they will be the one who will be handling the admin part about the case management features. When I'm talking about the admin part, because there are many cases you will be sending outside your network for second opinion or otherwise sharing. So when you're sharing it with multiple people. So at that particular process, you have to take care of your set of cases which has been assigned to different pathologists, because it has to be in a secured condition, and that's where your IT admin, your hospital IT admin will be training them, how to take care of those things. So those are the things which we take care at the readiness part. When coming down to the validation part, that's where we involve the pathologist. There are many guidelines which many people follows across, but the CAP guidelines is the one which is universally been taken care by the laboratories. Now coming down to the pilot program, so once a validation has been completed, because not all the pathologists, would be like freely going to the digital scanners. It is like a step-by-step process. So among this training, what we will be conducting, and once you're finished with your validation process, the pathologist should select some champions. And what I mean by selecting the champions is because the champions would be the one who would be doing the trainer kind of concept. So it would be like some of the senior pathologists, or maybe they may not be so tech savvy, especially when they are running with this algorithm. That's why the champions, who are the champions, especially in the digital pathology area, they would be helping the senior most, or the one who is lacking it out in the digital, where they find the hindrance in the scanning part. Here, even the vendors also do help, because from the vendor side, application people are also there. We also have a pathologist, Most of the vendors, they do have a pathologist, and especially when you're evaluating and doing the validation of the AI algorithms. Because in AI algorithm, what are the things needs to be taken into consideration? From the technical side, people will be supporting you. These are the set of tissues which we required, because they might be run in a set of protocols, and those if it is a Roche algorithm, because Roche antibodies are been run at a specific protocols, and in those specific protocol only the AI tool will be running, and they might be running in a different magnification. Now, if I look at it, most of the magnification, the AI tool will be running in 20x magnification, but some might require 40x magnification. Now, coming down to once the pilot stage is ready, then comes the full-scale deployment. Here, it means the entire set of the pathology team which is there. Now it's ready for the completely going digitalization. Now here also, if you don't want to go complete digitalization with the entire subspecialty, then you can go first, initially start with, say, dermatopathology, followed by breast and all, and then eventually going complete digital. So in a phase-wise manner, this can be deployed. Coming down to this AI and advanced analytics, now, once you have completed your evaluation for your primary H&E slides, followed by your cytology and path, then I would suggest to go with the AI validation. But in this also, AI validation, when you're doing the scanning, when you're evaluating for your primary reporting, that time only you can evaluate for your AI tools itself. Now, going ahead with this, how you can go live with your evaluation plan. So there are 3 set of category one needs to take care of it when you're going for the high throughput scanner. How would you, in scanning, go live? What are the things needs to be taken into the consideration? Now, in scanning go live, these are for the technical staff and the IT people who will be involved in the process for the scanning go live. Here, the pathologists are not involved. Once this set of scanning go live is ready, it goes forward with the pathologist go live. In this pathologist go live, they will be evaluating, they will be doing the validation followed by the in the real-time validation which we'll be doing, and then coming down to the stabilization. Now stabilization, when you're doing the dual workflow from the glass slide to the digital, that's where the transition will be happening. So it would be in a 3-step phase, you can do this evaluation. Now coming down to the challenge and challenges and in the proposed solution for DP. Now resistant to change, where we can moderate by education and training. This is how the champions will be taking care of it. And same followed by the workflow efficiency. We can develop a standard operating procedures. Now, when you are looking at the hub and spoke site model, hub and spoke site model also should be following whatever the hub is following, the same procedure, SOP procedure should be followed at the spoke site also. Not necessarily the spoke site will be having the bigger scanner, they might go for the smaller scanners. This is from the Roche side, which we have the image analysis.
Can you please wind up?
Yeah. So these are the set of image analysis which we have for the breast, which is readily available. And how it will improve the accuracy. Here you can see the for the breast case, the IHC, and whereas the HER2 dual IHH. Here you get the overlay with the different colors, where you can identify the amplified, the red and orangish color which talks about the amplified image, and the yellow area which you are looking at is the low amplified area. This is how the digital pathology applications help in the patient journey. Ultimately, whatever we are doing, we are looking from the patient perspective, and they get the value with the further treatments and all. And in the conclusion, one important thing, when we are looking into it, the immediate step, we should think about the current IT network bandwidth, and also one has to look into the vendor request proposal, focusing on the LAS interoperability. Thank you, everyone.